Welcome to our ECHO session today on GI symptoms and palliative care. I'd like to thank you so much for attending today. We are very appreciative, and we have a wonderful presenter, Dr. Golda Tradounsky, with us today. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. So briefly, the Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuing professional development among healthcare providers across Canada. We invite you to check out our website at echopalliative.com, and the Palliative Care ECHO Project is supported by a financial contribution from Health Canada. Many of you might know Pallium Canada for our LEAP courses. One of our most popular course is our LEAP course, LEAP Core program. It is an interprofessional course that focuses on the essential competencies to provide palliative care approach, and it is double accredited by the CFBC along with the Royal College. So a little link will be shared in the chat where you can check out further on this course. I will go over a few welcome and reminders. So I see already many of you introducing yourselves in the chat. Thank you so much for that. Definitely, there's a large number of you attending today. For questions, I would like for you to please focus on putting any questions you may have in the Q&A function, and the questions will be addressed at the end of the presentation. So focus really the chat for introductions and the Q&A for all of your questions. The session is being recorded, and we will email all registrants within the next week a recording. And please remember not to disclose any personal health information during the session. So briefly for the disclosures, Pallium Canada is a non-for-profit organization funded in part by Health Canada. And then we do generate funds to support operations and research and development from the Pallium pocketbook sales and the course registration fees. I myself, along with Dr. Tradounsky, have the disclosures as you can see on this slide. And the committee for the content, for the development of the content has independent control over anything that you see here today. So once again, my name is Diana Vince. I work at Pallium Canada as the Palliative Care ECHO Project Manager, and I will hand it over now to our presenter, Dr. Golda Tradounsky, to introduce herself.
Hello, everybody, and thank you for being here. Thank you, Diana, for this invitation. So I'm a palliative care physician. I work out of Montreal. In a small community hospital. I also do home care, and I've been doing this for like 25 years now. I've got some jobs at McGill as well, so all kinds of fun. Today, I'm going to say next for the next slide. We're going to be talking about GI problems, and next, please. We're going to be covering lots of things: constipation, nausea, and bowel obstruction, how to assess, how to treat. Honestly, today it's like a sprint, because I could talk for like practically 45 minutes just about constipation and nausea and bowel obstruction, all of them separately. So we're just going to try to go through this quickly, and I'll be welcoming questions, and I hope I have the answers. I don't have the answers to everything, but I'll do my best. Next slide, please. So for constipation, first of all, it's a very important problem, not only in our palliative care community, but also in our lay population, and that can worsen when the patient becomes palliative. So there's multiple causes for constipation, especially in palliative care, where people are not able to drink as much as they should. They should be drinking over, 2 liters of fluid a day to be able to keep on moving disturbing their bowels. They might be taking opioids. They might be taking other medications. They're not moving around as much. And we know that when people are not moving as much, their bowels won't be moving as much. So lots of reasons why our patients are going to be getting constipated. A good history means we're going to be asking lots of questions. Sometimes the first and most simple question is to ask them if they're feeling constipated. And if they feel constipated, there's a good chance that they are correct. They will potentially complain of discomfort, of bloating, of cramping. They will tell you the stool is hard. Sometimes it's not hard, but they feel like they just haven't had a complete evacuation. They might have to strain. Some of them might even admit that they need to disimpact themselves. Some of them will actually think they are not constipated because they'll be complaining of diarrhea, and they might not even be able to control this. They might have some incontinence with it, but actually this might be overflow diarrhea. And you need to ask them if before that they had been having issues of constipation. And then that might help guide you to realize that this diarrhea is actually overflow diarrhea from constipation. Interestingly, some people will actually become anorexic. They will have a lack of appetite. Why? Because they're already full and full of bowel movements, which they haven't evacuated. So when somebody's complaining of poor appetite, make sure you ask them about constipation. Some people might develop delirium due to their constipation, and certainly in people who have already issues of poor liver function, becoming constipated can lead to hepatic encephalopathy, delirium. In somebody who had underlying dementia, cognitive impairment, they might become very agitated, and it might, lead to delirium when they become constipated. Urinary retention can become a problem with constipation, and even urinary tract infections. Next slide. So as you can see, it's not just about asking your patient if they're passing bowel movements every day. It's asking them a whole lot more questions about, how much they're passing, what is the consistency, if they're feeling uncomfortable still, etc. Next slide. Well, we have to assess. So we're going to be looking at the abdomen, of course, and we look to see if they are having a distended abdomen. Sometimes they're not distended, but you can see a bit of masses. And then when you palpate, you might feel these masses. It kind of feels like a bit of a sausage, and that could be, kind of depressible, hopefully, if it's not too hard a stool. And you can auscultate as well. When we auscultate, what we're trying to do is make sure that we're not looking at an actual bowel obstruction versus the constipation. So you're going to be looking for normal bowel sounds versus absent bowel sounds or high-pitched bowel sounds, which could indicate bowel obstruction. And then if you are suspecting constipation, you should be doing a rectal exam. You're going to be looking at the anus for fissures and hemorrhoids, which might worsen the problem of constipation because the patients are having so much pain that they actually end up constipated instead of passing their bowel movements. And you're going to be checking the rectum for stool and also for masses, which could be obstructing the way. If you're not sure about your patients having constipation or not, you could actually get an X-ray of the abdomen, a flat plate of the abdomen. And what I do is draw an imaginary X across the X-ray, and then on one quadrant you'll have the ascending colon, the next quadrant you'll have the transverse colon. The other quadrant will be your descending colon, and then your last quadrant will be your rectosigmoid. And you can give a rating of 0 to 3 for each quadrant. 0, there's no stool in that quadrant. 3, it's full of stool. 1 would be less than 50% of that quadrant has stool, and 2 would be more than 50% of it has stool. When you sum up all the quadrants, you'll get a number out of 6, and if you have a number out of 12, I mean, and if you have more than 6 out of 12, then you can consider your patient to be constipated. Next slide. So, how do we treat constipation? Well, I would say that if your patient has stool in the rectum, you need to take care of that first, because you don't want to start giving PO laxatives in a patient who has hard stool or tons of stool in the lower bowel, because it means that the entire bowel is going to have to work so hard to get that stool out. And it's going to cause a lot of pain and discomfort. So if there's stool in the rectum, take care with local measures of that stool. With Dulcolax and glycerin suppositories, I like to give the both of them. It's kind of like a little bomb. Woo! Everything comes out usually once you get 1, 2, both suppositories, and then, try to get the patient to hold it for a bit. I think you guys know how to give the suppositories, but certainly making sure that they're holding the suppositories a bit, maybe like 15 minutes before they go to the washroom. And for some people, it takes a little longer for the suppositories to work. If it's a soft BM that you felt in the rectum, you can give a water-based enema. We tend to give fleet enemas, but if you give repeated fleet enemas, there is a risk of electrolyte abnormalities. So just a tap water enema can do the trick as well, just as well. If it was hard stool, I would say maybe start with manual disimpaction. Please, please, please be nice to your patient and give pre-medication, such as a little midazolam and a little bit of opioids to your patient, so that the manual disimpaction isn't going to be so painful for the patient. And then you can follow up with an oil-based enema, and that works well on hard stool. It just lubricates the rectum, it lubricates the stool, and then they can slide out more easily. And once you've taken care of the stool and the rectum, then you can start with PO laxatives. If the patient was already taking laxatives, make sure that you increase the dose of laxatives to prevent constipation from becoming an issue again afterwards. And if they were not on laxatives yet, then this is a good sign that they actually need to start on regular laxatives. And we should never stop laxatives. We can hold them temporarily, but we should, never stop laxatives if there's already been an issue of constipation. How to take care of patients when there is no stool in the rectum? You can start right away with PO laxatives, and osmotics could be as simple as prunes. Some patients we know really don't like taking extra pills, taking any kind of medication. So prunes can be a great idea for those people because there is some naturally occurring sorbitol in the prunes. PEG, which is that nice little almost tasteless powder, can be put into soups, Coca-Cola, coffee, tea, juice, water. So it can be camouflaged in pretty much any kind of liquid. Please do remember, though, that if your patient has issues of dysphagia and needs thickened liquids, you cannot thicken with the usual thickener anything containing PEG. So you should consider maybe using lactulose instead for that patient. Lactulose can be, mixed in water, mixed in juice, mixed in coffee, whatever, and then you can add thickener if you wish. And then there's also milk of magnesia, which is another kind of osmotic. It works quite well within 8 hours, unlike PEG, which might take 24 hours to work. But if your patient has pretty severe renal failure, milk of magnesia you can give occasionally, but you can't give it as a regular laxative because they might accumulate the magnesium, and that can cause another set of problems. There are stimulants that can also be very helpful. Senocide is one of them. And again, if your patient is anti-pills, you can recommend they get Senna-T from the natural food store. They have to drink maybe 1 teacup a day, 2 teacups a day, 3 teacups a day, whatever works for them to be able to get some nice regular soft stools. Bisacodyl is a stronger stimulant. Some people develop a little bit of abdominal cramping, but some people tolerate it well. And because it is a bit stronger as a stimulant, sometimes if a patient is constipated on Senocot, I might switch them to Bisacodyl to see if that will work better. I know that there's some recommended maximum doses. Honestly, in palliative care, we tend to go above the recommended doses. So I have given up to 12 pills of Senocot a day to patients. Same thing with Bisacodyl. When they're taking some strong opioids, sometimes they need a whole lot of stimulation. Now, if you feel that your patient isn't responding to the osmotics or the stimulants, and then maybe you even combined the osmotics and the stimulant, and they're still constipated and you think it could be due to their opioid, you could add an opioid mu blocker, such as methyl naltrexone, which is a subcutaneous injection. Very expensive, unfortunately. And I know that in Quebec, you can obtain it maybe with a patient of exception, but otherwise it's not necessarily covered by our RAMQ program. And I don't know if the province where you are, if it's covered, but it is an expensive medication and it's subcutaneous. So if the patient or the family member is uncomfortable giving themselves an injection, then it would have to be given by the nurse. Another mu opioid blocker would be nalexagol. That's a pill form, and it works quite nicely. You've got to add it to the other laxatives, and it works quite well. Sometimes you can actually stop it after they've, started having regular bowel movements and just stay on their previous other laxatives, and that will do the trick. For those people who are really resistant to all of these other laxatives, you can add on a serotonin 4 stimulant. It was formulated mostly for patients with irritable bowel syndrome with a constipation problem. Prucalopride, and I know that there's there's more molecules that they've developed, but prucalopride added on to the other laxatives can also be helpful for your patient. One of the things I'm going to tell you to remember is we should not be recommending Metamucil, psyllium to our palliative patients because they don't move enough, because they don't drink 2 liters plus of fluids per day. And so the fiber ends up causing retention of fluid in the bowel, but they don't pass it because they're not actually drinking enough fluids to distend the bowel enough and get that reflex colonic peristaltism. So they end up constipated on it. And in fact, I use psyllium in patients who have diarrhea, and that helps them form a stool, without that, having too much liquidy stool. So fiber is more for diarrhea than for laxation in our palliative patients. And I would say that even our geriatricians do not recommend fiber for their elderly patients who, again, are not drinking enough. And as I was mentioning before, if your patient starts passing way too much bowel movements, hold a dose, decrease the next doses, but try not to stop and encourage your patients to continue their laxatives. Next slide. So we finished constipation, and now we're going to go to nausea. There are many different reasons why a patient can develop nausea, and sometimes they have many reasons at a time to develop nausea. So the chemoreceptor trigger zone is certainly one of the very common causes in our palliative patients, as well as stimulation of the GI tract. By the way, stimulation of the GI tract, that could be irritation of the mucosa from really bad thrush, from esophagitis, maybe taking some pills, some iron pills, some anti-inflammatories. But another kind of stimulation of the GI tract could be distension of the bowels. Back to the chemoreceptor trigger zone, causes of stimulation of the chemoreceptor trigger zone could be the taking of some medications, such as opioids, but also chemotherapy. There's patients who have infections, and all the inflammatory markers in their bloodstream will actually cause the chemoreceptor trigger zone to say, hey, like, there's something going on in the body, and the warning sign that there's something going on in the body is that nausea. So you could also see uremia, hepatic failure, and even like a very advanced aggressive cancer can cause some releasing of tumor factors in the bloodstream, which will alert the chemoreceptor trigger zone that there's something wrong going on, and the patients will get nauseous. Hypercalcemia is another common cause of nausea for the chemoreceptor trigger zone. Increased intracranial pressure, stimulation of the vestibular system and the cortex, those are less frequent. So increased intracranial pressure, you could see that in somebody who's got metastases or even a primary cancer with lots of edema around the tumors, causing that increased intracranial pressure. Stimulation of the vestibular system, that can be due to cerebellar tumors. It can be due to tumors involving the eighth cranial nerve, but also morphine and the like could occasionally stimulate the vestibular system to cause a feeling of vertigo, which will then lead to some nausea. The cortex, and I would even say the limbic system, this is a diagnosis of exclusion. Make sure you do a good questioning to make sure that it's not the chemoreceptor trigger zone, the GI tract, increased intracranial pressure, or vertigo, before you start thinking, this could be a way for my patient to express their anxiety or depression, or sometimes even high levels of pain. And an example of nausea due to anxiety would be somebody who has anticipatory nausea before going to get their chemotherapy. So how to differentiate nausea coming from the chemoreceptor trigger zone versus stimulation of the GI tract? Well, the nausea from the chemoreceptor trigger zone, that nausea is going to be there pretty much continually throughout the day. There's not much relief from vomiting. In fact, there's no relief from vomiting. And they might say, yeah, the smells make me a little worse, but even if there are no smells, even if I'm not eating, I'm still nauseous pretty much all the time. With the GI tract, they can actually tell you, yeah, I've got nausea when I take this pill, or I have some relief when I vomit. Gastroparesis means that they will have this almost full stomach. They're eating a little bit more, and all of a sudden it's like, oh, that's it, I can't eat more. And if I eat one more bite, I'm going to get nauseous. And actually, they do take one more bite, they might actually start vomiting. But then once they've vomited, they feel better. So vomiting relieves the nausea from the stimulation of the GI tract. With the increased intracranial pressure, your patient will usually describe more nausea first thing in the morning, because they've been like lying down all night, and there's redistribution of fluids in their body, which means that they will develop more edema in their brain, and therefore more intracranial pressure come morning, and so they'll have more headaches and more nausea in the morning. So next slide. Wow, I actually will be flying through these next slides because I already mentioned all the things that can stimulate the chemoreceptor trigger zone. And like I said, you can elicit new medications. It could be accompanied by delirium, in the case of hyponatremia, hypercalcemia, liver failure, uremia, you could see some delirium if there's a potential infectious source. And you could do some blood work. If you're suspecting there's a chemoreceptor trigger zone involvement, you could do some blood work looking for signs of infection, looking for hypercalcemia, uremia, liver failure. You can do an infection workup. Maybe you'll do a urine specimen, maybe ask for an x-ray of the chest. You might do a delirium workup, which was probably, involves the blood work and the infection workup. Yeah. There isn't much that you'll find on exam except maybe some fever, maybe a distended liver, things like that. Next slide. For the GI stimulation, I mentioned already there's some NSAIDs, pills such as iron pills, thrush. You're going to have to look in that mouth, by the way, to look for thrush. Gastroparesis, constipation, bowel obstruction, even a distended liver could cause some nausea as well. So a good history, of course, looking for other things, like if you're suspecting gastroparesis, you could ask for early satiety. You could ask about reflux and porosis. And you will look in that mouth, you're going to check the abdomen, you could even consider doing a rectal exam if you think constipation could be at play here. A good investigation could, at times, include an x-ray of the abdomen, a CT scan of the abdomen if you're looking for a potential bowel obstruction. Next slide. Increased intracranial pressure. You could even have bleeds in the brain causing this, cerebellar tumors, etc. So the patient will often describe having a headache as well, along with the nausea. A good neuro exam could potentially help you pick up on some new focal neurological symptoms and signs, but not in everybody. Sometimes it's just personality changes and headache, etc. Changes in the mentation. And in a case of a patient whom you're suspecting increased intracranial pressure, then a CT scan of the head would be warranted. It's kind of hard, and we have been losing our skills with respect to looking for papilledema when we're doing an eye fundus, unfortunately. But I learned them a gazillion years ago. I'm not sure I'd be good at it now. Next slide. Stimulation of the labyrinth. I mentioned you're going to have a history of vertigo as well. And on the exam, you might see some nystagmus, some cerebellar signs when you're doing your neuro exam. And as I mentioned, a CT or an MRI of the brain could be warranted for some of those people. But if this happened right after they started an opioid, then you can suspect the opioid without having to do the MRI of the brain. Next slide. So I mentioned if we think it's the limbic system, we make sure we ask our patient, can you please describe to me what brings on the nausea, what helps it, and you could even say, when you're feeling more pain, when you're feeling a little bit more anxious, does that nausea feel any worse for you? And you might see that they might have the insight to say, yes, that the emotions has a play also in their experience of the nausea. But please do remember that you could have nausea worsening gastroparesis with nausea. You could have more anxiety and more depression in addition to uremia or to hypercalcemia. So a lot of things could be going on at the same time. Next slide, please. So how do we treat nausea? There's a variety of different ways, and certainly after a good history, good physical exam, you could probably think, okay, it's most likely due to, this pathophysiology versus another pathophysiology. And then you will look at the medications that are specific to that kind of pathophysiology. So that's one way of doing it. You could also say, more often than not, it tends to be either stimulation of the chemoreceptor trigger zone or of the GI tract. So let me choose a molecule that will cover both of these problems. So that could be another way. And then there's still another way, and it's to say, I'm just going to choose a molecule that whatever the underlying pathophysiology, it's going to help that nausea every time. So I'm going to show you here on this little table that there are some medications that are particularly helpful pretty much with every kind of nausea. So metotrimeprazine, you'll see, is an antidopaminergic and anticholinergic, and it works on the chemoreceptor trigger zone, on the GI tract, on the intracranial pressure, on the cortex, on the labyrinth. So pretty much, if you use Nosenan, I'm hoping that I said earlier metotrimeprazine, so that's otherwise known as Nosenan. Nosenan works pretty much in all kinds of underlying causes of nausea. Olanzapine, interestingly, of course, it's an antipsychotic, so it's an antidopaminergic, but it's also anti-serotonergic, and it's quite relaxing. It will work well for pretty much every kind of cause of nausea. We tend to use metoclopramide quite a bit, otherwise known as Maxaran or Reglan, and that's because it's got a nice antidopaminergic activity on the chemoreceptor trigger zone, but also will work on the GI tract, and it also help with the motility of the stomach and small bowel. So if your patient has gastroparesis, that can work quite nicely. Gravol works on the vestibular system, but it also works on the vomiting center. I didn't show you the vomiting center, but basically all these underlying pathophysiologies of nausea, they will go and tell the vomiting center, which is also in the brain, we've got to prepare to vomit. And that's where basically you've got all of the motor part of the vomiting that's being organized at the level of the vomiting center. So Gravol works to block vomiting at the vomiting center. So it works, but I would say it's not our usual go-to regular medication. It's more of our PRN, because people can get quite sedated with Gravol, and we would ideally like for our patients to have the best quality of life, which means that they are nausea-free and alert. So Gravol is okay as a as-needed medication, but not so much a regular dosing. And in some elderly people, because it has a bit of an anticholinergic activity, it can cause some confusion, delirium, so not ideal. I added some others at the very bottom, and the others we can consider adding Decadron or THC, because a decadron has an added benefit of being an antiemetic at the level of the brainstem. And THC has CB1 receptors at the level of the vomiting center. So it can help with vomiting, preventing vomiting. Maybe not so much to prevent nausea, but maybe a bit. So those are like, sometimes we have to add like some different molecules. For instance, even though metoclopramide might be good at the chemoreceptor trigger zone, if it's not enough to completely control the nausea, you might decide to add an anti-serotonergic such as ondansetron. If that wasn't enough, you might decide to say, okay, let me add some decadron and see if that helps, and or some THC to see if that's going to prevent my patient from continued vomiting. So I would say, you know, when you're doing add-ons, add something that comes from a slightly different, that works on a different receptor. It's of no use to add Haldol and olanzapine. I would just, you know, maximize the olanzapine kind of thing. Anyway, next slide. Okay, so now the last bit of our sprint, the GI obstructions. I'm saying sprint because there's so much to say, and I hope that you have questions that I can answer for you. So there's two kinds of GI obstructions, mechanical and functional. And with respect to mechanical obstructions, it could be from a benign cause. So we could think of adherences. We could think of volvulus or intussusception, but there's also malignant causes, such as a tumor that is invading the bowel and causing a local stenosis, or maybe compressing the bowel from the outside. And then there's, I don't know what this is. Okay, sorry, I was getting some vibrations from my phone. So all kinds of different kinds of malignant causes that can be, you know, endoluminal, transmural, and also external to the bowel. And then there's functional, where basically it could be the tumors are invading some of the myenteric plexus, so the nerves around the bowels, and causing the nerves to malfunction so that the peristaltism basically stops. And then again, more types of GI obstructions. So the GI obstruction could be relatively high. It could occur right outside the stomach, usually at the level of the duodenum. We call that the gastric outlet obstruction. And the symptoms for that is that the patient can have tons and tons of nausea, but some of them don't. Some have no nausea. Some of them just have lots of vomiting, projectile vomiting. And what they vomit tends to look like what they ate, you know, and some white fluid, gastric fluid that accompanies that. If there's a small bowel obstruction, there's going to be for sure tons of nausea. There's going to be vomiting, and the vomit will have the color of bile, so yellowish, greenish, brown. And there's going to be a little bit of abdominal distension, not much, but a bit. The patient looks slightly bloated, and there's going to be a lot of cramping. And that cramping is very acute, very intense, comes on soon after eating, and the frequency of the cramping, it comes, it goes, it comes, it goes. It's really quite intense. When it comes to a large bowel obstruction, well, one of the first things that will happen is that there will be no more passage of gas and stool. By the way, in small bowel obstruction, patients can still be passing gas and stool for a while, and then it's only after a prolonged lack of eating that the stool will stop. But large bowel obstruction, that tends to be one of the first things. And then they develop a lot of abdominal distension, and it can be really impressive to see how distended they get. And they will have cramping as well, but the cramping comes maybe a couple of hours after eating, and it comes and goes. It's not going to be quite as cute, and the frequency of the cramping will not be quite as intense as what we see in small bowel obstruction. Nausea may occur, but much later on in the clinical picture for a large bowel obstruction. Next slide. So again, a good assessment, a good history. We want to hear whether there's nausea, vomiting, abdominal distension and pain, passage of stool and gas. We will examine. So again, we look. Are they distended? We listen. We're looking for any kind of bowel sounds. Remember, functional obstructions, there will be no more bowel sounds because the bowels are pretty much paralyzed from the tumors invading the myenteric plexus. If there's high pitches or increased bowel sounds, that could certainly indicate a mechanical obstruction on the other hand. But do remember that if that mechanical obstruction's been there for many, many days, there will be a point at which your bowels will just get exhausted of, trying to fight that obstruction, and they will also kind of quit. So you may hear very few or no bowel sounds later in a mechanical obstruction. You want to palpate the abdomen, and you want to do a rectal exam. One of the reasons why we're doing a rectal exam is, again, we're looking for stool. We're looking for a mass that could be obstructing the rectum. Sometimes people have such bad constipation that they actually develop GI obstruction, and it looks exactly like a malignant obstruction, even though it's just from a bad fecaloma. So do the rectal exam, please. And the best type of investigating for a GI obstruction is to do a CT scan of the abdomen. Next slide. There will be people who will be surgical candidates. Before this GI obstruction, they were doing relatively well with good functional status. One would have expected the prognosis to be of many, many months. So they were doing well. Their albumin levels were good. No prior radiotherapy to the abdomen, because when there's been radiotherapy, it's a little bit harder for those tissues to repair themselves. So they end up having lots of complications from getting abdominal surgery. If the patient has ascites and it's recurring ascites that needs to be tapped frequently, they're not a good surgical candidate, because the ascites that's reaccumulating is going to push on all of those wounds from their surgery and prevents the patient from having wound healing. If there are multiple sites of obstruction, not a good candidate, because you can't make Swiss cheese out of the patient. If you're feeling lots of masses also when you're examining your patient, not a good candidate, because even though you might be repairing one side of obstruction, maybe in a week or two from now, they will develop a new obstruction from one of those large masses that you were able to palpate. The benign causes of obstruction are good and easy to repair for somebody who had a good functional status. So a benign cause is the surgery is a consideration. So if your patient is not so much of a surgical candidate, or they don't want to go through surgery, then there's the option of stent, and these are metallic stents. They have to be put in through scopes. Excuse me. So you need to have a gastroenterologist who can, assess and see if this patient is a candidate for receiving a stent. But unfortunately, not all patients can get surgery or stents, so then we've got the medical or palliative treatment. Next slide. So the first thing that we have to consider is putting our patient NPO. They're not going to be able to tolerate any of their medications. They're not going to be able to tolerate food and fluids. All the medications need to be stopped PO, and then those that you can switch to subcutaneous or transdermal, and in some patients even intrarectal, that could be an option for those people. One of the mainstays of treating a bowel obstruction is the use of dexamethasone, Decadron. We have to remember that where there is a site of obstruction, there is going to be some inflammation. And certainly if it's a malignant cause of obstruction, well, where there is that tumor, either compressing or intraluminal or whatnot, where there's that tumor, there will also be a reaction around that tumor from our own immune system, and that inflammatory reaction causes edema. And that edema, if you can decrease it with the Decadron, then you're going to decrease your mass effect on the bowel. So the use of Decadron might actually help you reverse the bowel obstruction. It also is good for pain, and it's also good for nausea. So dexamethasone has multiple uses for a patient with a bowel obstruction. Hyoscine butyl bromide, which we also know as Buscopan, can be given subcutaneously. And this is a medication that is anticholinergic. So for a patient who's got a lot of cramping, with an anticholinergic, you can really slow down and even stop the cramping, which gives your patient a lot of relief. As well, we know that anticholinergics can decrease the amount of secretions being produced, let's say, in the stomach and even saliva. We know that we produce a lot of saliva and we produce tons of GI secretions from our stomach, our pancreas, etc. Well, hyoscine butyl bromide as an anticholinergic will decrease the amount of secretions, so you'll have less buildup of fluids upstream of the obstruction. And one of the reasons why patients are nauseous is because upstream of the obstruction, you've got all this distension from all these secretions that are accumulating. So if you can reduce the amount of secretions and reduce the distension, you will secondarily reduce the nausea. Octreotide, very complex molecule, very helpful again, especially in gastric outlet obstruction and in small bowel obstruction, but can be used as well in the large bowel obstruction. Octreotide will help reduce the amount of cramping, will help reduce the amount of fluids being released, and so overall, it can be helpful for nausea and pain. As well, it has, along with the Decadron, an ability to decrease the amount of edema. So the dexamethasone and the octreotide together can help relieve some of the obstruction for some people. Not everybody, but for some people, you do get reversal of the obstruction. And then you'll think of, adding opioids and other antiemetics. Please, no metoclopramide, because you do not want to give something that's going to stimulate peristaltism. So no metoclopramide, but a lot of the other antiemetics, things such as haloperidol, olanzapine, and whatnot can be helpful. H2 blockers and PPIs to decrease the amount of gastric liquids. D&G suppositories can still be given to people who have like a small bowel obstruction to prevent the constipation from adding on. I said optional hydration. Honestly, I try to minimize hydration because I'm trying to minimize that third spacing upstream of the obstruction. So I just tell patients to suck on ice cubes, drink a bit of water, see how they tolerate it. And I only give hydration if there is a clear purpose for that patient, such as, trying to live for another week or so, to get a chance to see a family member, or if for cultural or religious reasons, it's absolutely necessary. Next slide. So what I would basically tell you is that for GI obstruction, sometimes we give sub-Qs, TID or QID. If it doesn't seem to help control your patient, consider a continuous subcutaneous infusion of a combination of these medications, the antiemetic, the Decadron, the Buscopan. Sometimes putting it all together in one infusion will help much better control your patient's symptoms, and we cross our fingers and hope that there will be a reversal of the obstruction, but at least minimally good relief of their symptoms.
Fantastic.
So that was my sprint.
Thank you so much, Dr. Tradounsky. I wanted to take the time to dive into a few of our questions, if time permits. I'll start with the first one from Pan Mansfield. How do you give the Dolcokes first, then glycerin sup, or both at the same time? Which one do you put in first, and does it matter?
So yeah, well, I ask the nurses to put both of them in. And the Dulcolax, what it's going to do, or Bisacodyl, what it will do is it's going to stimulate the peristaltism. So a good nurse, an excellent nurse, my head nurse now, has taught me that the Dulcolax, there's a little indentation in the suppository, so you can sort of almost orient your suppository when you're putting it in. And she told me it should go against the mucosa to really help that mucosa get that benefit of peristaltic activity. And then the glycerin is there more as an emollient, so you can shove that right into the stool. It doesn't really matter, but you can put both of them in at the same time. 1, 2, one against the mucosa, Bisacodyl, one anywhere you want.
Fantastic. We have another question. It says, can you comment on the recent literature on the efficacy of using isopropyl alcohol for nausea? Any studies in the palliative setting thus far? Do you have any thoughts about that?
I have no thoughts. Sorry, I'm not familiar with the use of isopropyl alcohol. I think I'll have to read up on it myself. Yeah.
Yeah. From Gina Villegas, we do have a question. What is the reason why PEG and thickener can't be mixed together? I just want to understand. Thanks.
Yeah, it's just weird. They don't want to, the thickener won't thicken. So when I want to continue using laxative but have to thicken the fluids, I use pectin instead. The stuff to make jelly and jam. You can get that obviously from the food store, and you can use pectin and thicken the PEG, and that works. Otherwise, just if you want to remain with the thickener, just use lactulose instead.
Fantastic. And regarding that, there's another question saying, is putting PEG in applesauce for dysphagia effective?
It could work, absolutely. I think our nurses have done that in the past. Yeah.
Okay.
Yeah.
Do you recommend prune juice?
Yes, I do.
Yes.
Like I said, there's sorbitol in the prunes, so it works as an osmotic. It's got some soluble fibers as well, but because it works as an osmotic, it's going to bring fluids into the bowel. Yeah.
And is there a link between nausea and sudden falls in blood pressure?
What a good question. I'm going to have to dig my brain a little bit. I guess it's an autonomic nervous system thing, and nausea certainly. We know that with autonomic nervous system being stimulated, vasovagal reactions, yeah, you get nausea with that. So probably it's through the autonomic nervous system.
Okay. What would Nosenan dosing be for nausea?
Well, in the UK, they use these itsy bitsy little doses, even 1 milligram. So, when you use such a small dose, there's probably minimal sedation from that. But you could start with 2.5, 5, and then work your way up to whatever your patient needs and tolerates.
Okay.
Um, I would probably start with the lower doses because I don't, like I said, ideally for quality of life, I don't want to knock my patient out with some Nausean méthode prémédicative,
Yes.
complicated
Yeah.
name.
And would you combine two anti-nausea agents for best efficacy?
Well, like I was saying, if you have one patient on one kind of molecule, reaching one particular receptor, let's say the dopamine receptor, and you think this is chemoreceptor trigger zone. Well, we know at the level of the chemoreceptor trigger zone, there's the dopamine receptors, but there's also the serotonin 3 receptors. There's also neurokinin 1, which I didn't mention here because it's a medication that you don't, aprepitant is something that's used more by the oncologist than in palliative care. But all this to say, if I wasn't getting what I was looking for, not enough efficacy with one molecule, I would be looking to add another molecule that would go to work on another kind of receptor. So pairing an antidopaminergic with an anti-serotonergic.
Fantastic. For large bowel obstructions and palliative, do you ever use soap sud enema to try to move obstruction?
So we've been told not to do that anymore because soap suds can be extremely irritating to the mucosa.
Mhm.
So tap water enemas to start off with. If that doesn't work, go ahead and use a fleet enema. Fleet has extra salts in it, so it will cause some osmosis into the rectum. That's why it's even more effective than a tap water enema. You can use a lactulose enema, also osmotic, etc. But the soap suds enema, not recommended because you can cause some damage to the mucosa.
Okay. Palliative patients who have been NPO for a bowel obstruction know. Oh, sorry about that. It goes down when questions are added, so it just went down a little bit. So no investigation, surgical treatment, no IV fluids, but requesting to eat. Should we be advocating to continue with ice chips only or allow intake for QOL and manage symptoms?
Well, so you know what? Like I said, I could have talked for hours for each of these subjects. I want my patients' quality of life to be as good as possible. So they really love the taste of food. They are in complete obstruction. They easily get nauseous when they're taking their ice chips and drinking a little bit of water. I would say, listen, get some of that food in your mouth, chew it, spit it out.
Yeah.
If that makes them happy enough, great. Some people will insist on swallowing and won't mind vomiting. If they don't mind vomiting, that's fine. Again, it needs to be so person-centered. Forget patient-centered, but person-centered. There are people in whom there is absolutely no way of controlling their nausea, etc. There is the possibility of putting in the equivalent of a peg. So peg, and this time it's one of those tubes in the stomach, and it's called the name venting tube, a venting gastrostomy tube. There, the name all came back. And so that would be put in by interventional radiology. And so even though the patient has a complete obstruction, they can eat, swallow, and then they can let out the contents of their stomach by opening up that venting gastrostomy tube over a toilet bowl or a basin, whatever. So then they can eat a little bit. Maybe some of it they'll be able to actually digest a bit, but the large quantity that they would have otherwise vomited, they can empty out.
Okay. And I'm gonna wrap up the session with this question. So what about cannabinoids? Are you using in your practice, or is there any role for CBD, do you find?
CBD can be interesting for patients who have anxiety.
Mhm.
So if you think that part of your patient's nausea is due to anxiety, um, you can try CBD. We now have the oils. You can go with really small doses, work your way up. I've seen people get quite sedated on CBD, so that's why I'm saying, start with small doses and work your way up. And if it helps their anxiety and helps their nausea, because the nausea was secondary to the anxiety, then great. But otherwise, THC would probably be more helpful for the vomiting and maybe secondarily for the nausea. I'm always careful with THC because there's such high risks for patients to develop delirium on THC. So I would tend to pair this THC with the CBD. Again, work with really small doses, work my way up, and see how the patient tolerates. The cannabinoids are not my first line treatments, unless I think I'm going to hit many different problems with the one medication. So if there's muscle spasms and nausea and anxiety and insomnia, I might say, okay, let me actually go with a combination THC, CBD, and see if I can, help with all of these symptoms with just the one medication. But otherwise, they are not the first or second line medications that we go to. They're the third line.
Okay. And so I just got some. Yes, so we have quite a few movement on one of the questions, so I'll ask it briefly. In a patient getting to end of life with very limited to no oral intake, at what point are you okay with no BMs? At what point is it just that there isn't much left in the system to produce bowel movements versus the patient being constipated?
I'm still debating. As I'm getting older, I'm feeling more flexible. So once upon a time when I was young, and I'm not young anymore, I would say, okay, no, I'm going to keep on giving Dulcolax and glycerin suppositories every 3 days for my patients to try to eliminate every 3 days. Because if I think, the prognosis is of maybe a week or 10 days, I wouldn't want them to start getting uncomfortable. Nowadays, I am less rigid, and I kind of play it by ear. And some families say, please, please, let's not bother him. If the patient doesn't have abdominal distension, doesn't have abdominal pain, hasn't been eating in many days, I might just observe and wait and see what happens. But we do have to remember that the inside lining of our GI tract gets sloughed off every day. And there will be some fecal material forming every day. So as long as the patient isn't uncomfortable and the family really is resistant to having some suppositories, I let it slide. You see, I'm getting softer as I'm getting older.
There's nothing wrong with that, I would say. So I will wrap it up and say a great big thanks to all of our attendees today. We were thrilled to have you with us today. We've included a feedback survey in the chat. We invite you to let us know what you think about this session. And of course, many of you are already letting us know through the chat. So thank you so much. And yes, a recording will be sent of the session, of course, to everybody who registered. So you will have a chance to see the slide deck along with the recording. Dr. Tradounsky, thank you so much for being with us today.
My pleasure. My pleasure. I know that it was speedy, but I hope it's helpful.
Thank you so much.
Thank you.